So Dr. Lauren Loewen hails from wonderful Wichita, Kansas, and him and I share the same passion for pursuing the simplification of the placement and restoring dental implants. And today he's going to talk about the one-stage dental implant. He has graduated from the University of Missouri, Kansas City Dental School. He's a class of 1988. I'm a class of 1999 in Toronto, University of Toronto. Dr. Loewen has over 30 years of dental implant experience. And then, although he has received various diplomats, fellowships, and awards in the dental implantology field, again, I want to say I don't hold a candle to that, but we do share that same passion of continually pursuing simplifying the placement of dental implants and restoring them. And he's going to share the clinical side of the one-stage dental implant. And if you want to learn a little bit more about the research part of it, I will be more than willing to entertain the thought of handing you some research to support the immediate loading capability of our one-stage implants. But Dr. Loewen has placed all of our implants. He's experienced in placing all the different types of implants, but today he's going to concentrate on the one-stage dental implant. And without further ado, let me introduce you to Dr. Lauren Loewen. So take it away.
All right. I think hopefully you all can hear me now. So yes, I am in Wichita, Kansas. Just a little bit about myself. Been in this for 34 years. I have worked with implants during that whole entire time. My dad was a dentist. He introduced me to implants because he did implants about 50 years ago. And so we have a long history. And what I found out was over the years that it was important to be able to restore implants as well as place them. And that really improved the efficiency of what we were doing. It was a lot more fun. Actually, I'm hoping you guys are excited about one-piece dental implants because it's really a fun thing to do. I'm going to get into that real quick, but I just wanted to thank you all for showing up on Friday. Yes, it's Friday. And we're going to have a little bit of fun with this. So moving on, are we ready to go here? We're having a little technical thing here. I think we're going to get in here. But I do want to give everybody the heads up. There is a little quiz at the end of this thing. It's very easy. I'm going to give you big hints going through here so you can get your credit. I want everybody to get credit. And gosh, it's Friday. Don't want to be too hard on anybody on Friday. So as we go through this, I will give big hints on what the question might be, and so you can get the answers all right. So I'm still working on getting to my red screen. Am I where we want to go now? I'm asking my helper here, my side. We've been chatting. I hope everybody can hear me. I'm going to get started. So there's a rationale for one-piece dental implants. I think it's very underused, and I think it's a sad thing that a lot of people don't even know about them or have much understanding of them. Some of you, I'm sure, are doing some of these. First of all, as far as advantages, I'm going to try to go through some advantages, some disadvantages. I also want to describe what I would consider a one-piece dental implant. So everybody's used to bone level implants, to tissue level implants. I think most people are familiar with that. So a one-piece dental implant, just for definition, is going to be basically it's an implant where the abutment and the implant, what goes through the tissue into the bone, is all one piece of metal. So if you think about it that way, it's very, very simple. It eliminates a lot of things. There are some other considerations that are very unique to them that people do need to understand. So believe it or not, mini implants would be considered a one-piece dental implant. So I'm going to talk a little bit about that. That's definitely not the focus of this meeting, but there would be mini implants, and then OCO makes a whole line of standard sized one-piece dental implants. So they make minis also as well. The one thing about the placement protocol for everybody to understand that's important, first of all, is it's going to be almost exactly the same as it would be for a standard implant. If you are familiar with OCO dental implants, everything that goes in the bone is the same. Whether it's a one-piece dental implant, whether it's a TSI implant, whether it's a bone level engage implant, they all look exactly the same. It's what's above the bone that changes. So your placement protocols for a one-piece dental implant are exactly the same as they are for a engaged bone level implant or one of the other ones. If you're going to use, now this is getting away from OCO for a minute, there are some things that you want to make sure you have for a one-piece dental implant. The main thing is I would highly recommend, well, it has to be an implant that's able to be immediately loaded. So a one-piece dental implant by nature, because it comes through the tissue into the oral cavity, whether you put a tooth on it the day you put it in or whether you sit there passively, it is to some extent loaded. Okay, there's going to be some stress on it, whether it touches the opposing occlusion or not. People are going to chew on it. If you're hooking a denture on it, of course it's loaded. If you put a temporary tooth on it, it is going to be a loaded implant. So what are you looking for there? You want one that's going to be self-tapping. You want one that has aggressive thread design. You want one that's probably going to tend more toward a tapered design. You want to have some initial stability that's really good, because that implant needs to be stable while it integrates. No matter what load you put on it, it has to be stable. If it moves, it's not going to make it. So it's a very simple idea, but that's very important to understand. Another thing about the one-piece implants is it's going to greatly, this is probably the biggest advantage, it greatly simplifies your prosthetic protocol. So your prosthetic protocol is, if you're doing it for loading teeth, a bridge, a single unit tooth, it's almost like regular crown and bridge. In some senses, it's so easy, it's almost embarrassing to say, but it can seem so easy when you go from, so back to my history, I'm going to interrupt myself for a second. So I've gone through the whole gamut of implants. I've used all the types of implants that I can think of that are out there. My dad used blades, we used periosteals, subperiosteals, single tooth implants, what we consider the norm for the day. I've gone through bone level, tissue level, all that stuff. So I've been through some pretty complex protocols, but the one-piece implants has an extremely simple prosthetics protocol because your abutment is there. You do have to learn to manage some soft tissue issues, and I'm going to go try to hit a couple cases that show that to you, but it's pretty simple. So for me, it was like, oh, this is like regular crown and bridge. All of a sudden, I'm away from all this other stuff that I was worried about all the time, and it's gone. So that's a big advantage. The next thing, if you're following on along my sheet here, the biological advantage. Of course, when you go to a one-piece dental implant, I'm going to stumble on that word, you're basically getting, so you no longer have a connection that's at bone level. Okay, so you're getting basically you're getting out of the sewer. If you think of it that way, your mouth is loaded with all these bacteria. We got a bone level implant there. We got a connection at that bone level. If you've seen any of those videos with the dye staining and the pumping action, when an abutment gets pushed back and forth and all the fluids that flow in and out of these things, if they're a bone level implant. So you're getting rid of that. You're done with that. You'll see on some of the cases I'm going to show you today that the bone level doesn't change. So even over years of service, we don't see that bone level issue going on because we've gotten away from the bone level connection. That's going to be true with a tissue level implant, just the same as it is with a one-piece implant if you want to use a TSI. So, which is OCO's version for a tissue level implant. Other tissue level implants may be out there. I've used several different ones, but I wanted to point those out. So the other thing that you can think about too is the strength of the actual implant itself. So we've just gotten rid of the hollow core implant when we go to a one-piece implant. So if you think about it, kind of like it's just like a hollow core door compared to a solid door. If you have a house that has both kinds on it, you'll see the difference. If you go to, they've done some breakage studies. I don't have that literature in front of me at the moment, but I can say with confidence that you can go to a smaller diameter, one-piece dental implant, compared to a implant with a connection. I don't care what kind it is, but any kind of an abutment screwed into it, you're going to see that you can probably use a 3 millimeter or a 3.25 millimeter implant. That implant is not going to break as easily as a 4 millimeter bone level implant, because now you've got, look at the volume of metal you have going right down the center of this implant that you're not going to have because you have a hollow abutment screwed into a hollow implant. So your strength, you can do some things prosthetically with a one-piece dental implant that you wouldn't think about doing if that implant was a hollow core implant. So you can get away with a smaller implant and get the same strength for your prosthetics as you would with a bigger implant. Prosthetic management is, like I said, similar to natural teeth, and you're also going to notice that there's going to be a significant cost savings, okay? So pay attention to the part I said about one-piece implants having superior strength compared to screw-retained abutments, because that's one of the questions on the test. The answer probably ought to be true on that one. So the one thing I do want to tell you, I'm going to advance this to the next one. So if you're going to take that test, you might pay attention to that little bit of information I just gave you. So I've already mentioned the implant design considerations that are on your slide here. Moving on, OCO does make a full range of one-piece implants all the way from 2.2 to 5.0. As far as abutment options, there are a few different options for abutments. So keep in mind that these are abutments you're not going to change out. So if you do have a case where you're anticipating you might go from a denture to a fixed scenario, and you're using a one-piece dental implant, there are cement over abutments that will make that conversion possible for you. Now, if you go to a fixed case, and then you want to switch to a denture case, that's not going to happen very well, because you can't unscrew a CB abutment piece and put in an O-ball or something like a locator. So those are the ways you can go, but I usually hardly ever have that happen. Actually, I've never had that happen in my practice. I have had patients go from the denture and want to go to a fixed. So bone requirements, ridge expansion and osteotomy. For one thing, if you can go to a smaller diameter, you'll find out that you don't need to do as much bone modification. So if you're doing a case where there's not as much bone to put in a 4 millimeter implant, if you can put in a 3 millimeter implant, and you can do it without having to do a bunch of ridge expansion or grafting to make that happen, then you can be in good shape. And so you can do cases that you wouldn't consider doing before with this type of an implant. So there's some advantages there that I think it's unfortunate that we don't consider it terribly often. So one thing I do want to say about ridge expansion real quick, I have that notation there. With the mini implants, one thing I learned about was that mini implants expand bone pretty well, because we don't make the osteotomy near as big as the implant. So, and OCO's implants are all tapered, so your osteotomies are a little smaller. You're getting some bone compression. But I actually have noticed that there are cases where I'll take a mini implant where I'll have if the patient's young enough, and I can put a mini implant into a spot without having to do a full osteotomy, back that mini implant back out, and then screw in a larger diameter implant. That's my ridge expansion. So that works in some patients. It won't work on an 80 or 90-year-old, but it will work on a patient that's in their 20s or 30s. And it works pretty consistently. Osteotomy techniques, again, they're going to be more conservative because you're going to do something that's immediately stable. Bone volumes and density. I do want to mention that on my next bullet point. Bone volumes are basically the same requirements you're going to have for any other implant. Just keep that in mind. That really doesn't change. The immediate load protocol for one-piece dental implants, and there's something that Dr. Delick has an article about. We have found, well, there's some pretty good research to support this, that it's called the bone buttress theory. So if you do an immediately loaded implant, you're actually going to speed up the osseointegration. And I'm going to let her get into that because she's going to bring that up in another meeting. So, which puts a plug in that'll happen later on here. But what we know is that it increases the rate of osseointegration if the implant is loaded immediately. And we know that we're going to get actually some better bone. So those are one of the things that you have as an advantage. There are cases where a one-piece dental implant should not be used. I have a pretty good protocol for that. I don't know if I have time to get into all of that, but if you're trying to put a one-piece dental implant and load it in type 3-4 bone in the maxillary posterior, you may have a problem. So there's times when I will not choose a one-piece dental implant for sure. It's a good part of my practice, but if I'm trying to put in a single molar that's standing alone in type 3 bone and I load that right away, I may run into a problem. So you do have to understand that there are limits. If you do overload and exceed that point, then you may have a problem and get some implant mobility and you may have a failure. So we talk about that. So I do want to make sure that you understand that these aren't like a one size, one thing fixes everything. I always believe that there's good implants for everything you do in dentistry. If you're in the implant world, you need to pick your implant for your situation. One-piece implants are great for many situations, but there are times where you should use something else. One of the other times where I will see an issue with using a one-piece dental implant is if the alignment. So if you're talking from a prosthetic point of view, we always plan our cases prosthetically down. In other words, we're going to figure out where that tooth is going to be before we place our implant. We're going to do that on our 3D scanning. We're going to make sure that I can fit that abutment from that one-piece dental implant where I have to, depending on where that bone is. So if I have a case, let's say in the maxillary anterior, where my bone is flaring to the facial, and I need to get that tooth back in toward the palatal, I can't always use a one-piece dental implant because I need to use an angled abutment. So there's cases where you cannot use the one-piece dental implant because you won't be able to get that in the bone and successfully line that case up. So again, you have to use your head a little bit and use your 3D scanning and do your planning ahead of time. So prosthetically driven planning is important. I use a lot of prosthetic wax ups, especially on full arch cases. And we make a clear acrylic stent. You can call it Trutane or one of the other clear plastics that you want to use. But you need to make a clear stint, in my opinion, when you take out teeth and you're wanting to make sure that your implants, when you place, are falling within the parameters of those teeth. So a clear stint works nice because you can look right through it and you can see, hey, does this abutment line up with my tooth? Is this going to fall within the parameters of my restoration? So I use that quite often. You can use guided implant placement techniques. A lot of people are using guides. I've used them and they can help you with that as well. So parallelism concerns are our next item here, especially important with multiple units, of course. You have to get your parallelism acceptable for your prosthetics. So one-piece dental implants, one nice thing is you've got a whole lot of metal that you can prep. So you're back to prepping like a natural tooth. You're going to prep your abutment so that it's parallel enough that your restoration is going to fit. So if you have a roundhouse case, you've got to keep that in consideration with your planning and also with your prepping of abutments. The nice thing is these implants are very stable. You can prep these abutments the day that you place them. You can also scan them if you're confident. In most cases, I do this. When I'm not taking out teeth, I can scan the abutment with an iTero scanner or whatever scanner you happen to use. And you can get your prosthetic, you can get your crown made. You can get it going while that implant is actually the day that you place it. So you can place your crown at the very next appointment if you desire to do that. So those are some really nice things. Next item here is, when is the two-piece or bone level warranted? I kind of covered some of that already. When you need a custom abutment, when you need complete passivity. Smokers are another one where I will shy away sometimes from placing a one-piece dental implant if I am not convinced that they can slow down their smoking, or if I am doing an immediate case where they're a smoker, where I'm placing implants, I'm going to bury those things. I don't want to leave that metal coming up into that mouth that's going to get contaminated with all that stuff from smoking and get plastered with some tarry stuff that's going to keep my implant from integrating. possibly. So those are some protocols where I would shy away from using a one-piece dental implant. Lab considerations, one thing about a digital scanning workflow, it's really nice if you do scan these cases. I'll try to show you that in a little bit on some cases. I have the lab send me over screenshots after if I set the margins myself, fine. Sometimes I don't, I let them set them. If they're setting those margins, they send me screenshots, they show me parallelism. Sometimes I'll use reduction copings, and I've got a picture of that coming up here. There's all kinds of ways, but again, you're back to doing something a lot more like conventional prosthetics. So there is one other thing, if you're doing a digital workflow, all of these, I want to say this now because I might forget about it. If you're scanning one-piece implants, there's a slot in those one-piece implants that your driver fits into. It's an external slot that you're going to use to drive down your implants. So keep this in mind. When you have your lab make your prosthesis, they need to block out some of that slot, okay? If not, those mills, if you're doing milled crowns, especially, you know, any kind of the monolithic type of materials, zirconia, whatever you might be using, those mills cannot accurately reproduce that slot. And if you don't tell them to block that out and use enough block out on there, you're gonna have a heck of a time placing your crowns. If they just block that out, they'll seat right down, no problems. But you have to, that's one thing I've learned, but especially if you have multiple units, they've got to do something about the slot, or you may have problems seating your crowns. So I've covered the basics. I wanted to get through that, a little bit of housekeeping here. A couple other questions I want to make sure on the quiz part. Another question I had, one-piece implants have higher success rates in low density bone, true or false? Well, I would say you better say false on that one, because you go to low density bone, you might be one to think about a unless you are very confident you can keep that thing passive enough so that they're not overloading it with chewing. I would say false on that one. So that's a question you want to remember. One-piece implants can be immediately loaded in all situations. I would say that's also false. There are situations where I'm doing multiple units, I'll load them almost all the time. If I'm doing a single crown or maybe two crowns, two implants in a row posteriorly, I'm going to keep them out of occlusion. I'm not going to put a crown on it right away the same day. They're going to load it enough just from chewing to get the stimulation they need for that integration to be accelerated. But I usually don't stick a crown on those. I might scan them. I might put a crown on in 6 to 8 weeks, but I'm going to leave them out of occlusion, okay? So the other question I want you to make sure you know, when using one-piece implants, it is okay to prep the abutment in the mouth the day of placement. So yes, we do it all the time. The other one is, so that would be a true. The other one, anterior tooth replacements can often be accomplished with one-piece implants with aesthetic results comparable to that of bone level implants. There's some people that are going to argue me with that, but I'm going to show you some cases that show you that, yes, that is true. We consistently get aesthetics that are just as good using a one-piece dental implant as I've ever been able to get with a where I've done with a two-piece implant or a bone level implant. So having said that, I'm going to put this away. We're going to move on to some cases, because I think that's what a lot of people are probably going to be interested in doing. So the first case I'm going to show you is something that happens all the time in my office. This is a patient that came in. She's a super energetic 75-year-old lady. She's in good health. She fell, broke off her front tooth, okay? Everybody's seen this. You guys have all had cases where they've had crowns for 20 years, 30 years. All of a sudden, they fractured the tooth off. They're in your office. What can I do? Doctor, can you help me? Can you put a tooth back in here? I need this tooth right away. So this is the case where we had actually seen this patient before. We had done an implant and a crown on number 4. It's up in here. Let's see, 4 on this one. I think it's over. Actually, that one right there. That's a crown that we did a couple of years earlier with a one-piece implant. So anyhow, she came in my office. She broke off this tooth. I had one of these happen just this week. We have it happen on a regular basis here. So we're going to talk about putting in an immediate implant. So the protocol with this is, if you're going to do an immediate implant, just please make sure there's not a periapical radiolucency there. I think you can take this out and graft graft a location like this that has a periapical radiolucency and get away with a grafting it immediately. But I wouldn't want to put an implant in a location like this if there was any chance that it was going to infect it. So these cases happen a lot of times. There's no infection at all. There's no radiolucency at all. They might be endodontically treated, or they might even be vital yet. So a lot of times this is very possible to do these cases the same, that day if you have time on your schedule, but within a very short time, we can get them back into an implant in a tooth. So I'm going to walk you through this case real quick. So here she is, a couple of console anterior views, and here we are with our scanning, our planning scan. So you can see on the left side, I have a green abutment cylinder on here, so I can line it up and make sure that the crown of my tooth is going to line up where it belongs. The next screen is actually the implants in place. It should look pretty much like a twin of what we had. So usually we're always going to put these toward the palatal orientation. We're going to hit that triangle of bone right behind the socket. And I'm going to go as long as I can. I'm going to put as long of an implant in there as I can. I want to get at least 50% of my threads engaged in bone. The rest of it, I'm going to graft around it and we're going to restore it. So here's our x-rays, same day that we placed it. We didn't actually do this the day she walked in. I think we got her back within about 3 or 4 days. So you can say that this implant pretty much obliterates the socket. A lot of the socket is, except for facial to the implant, it's engaging bone. So this implant is probably 75% engaged in bone. So, and this is definitely a one piece. You can see the abutment here. You can see all these teeth are endodontically treated except for the one we removed, but the tooth root was still healthy. So here's our same day that we placed the implant. Here's our abutment in place. Atraumatic extraction is critical. You have to learn techniques where you don't blow out the buccal bone. Sometimes it happens, you blow out the facial bone in this case, and you have to, if you still have enough bone palatally to stabilize your implant, which you usually will, even if the facial bone is gone, you need to have a technique for putting in a membrane and restoring that socket, which happens with not a huge amount of regularity, but it does happen. So here you have before and after, tooth in place, tooth out, implant in place. And here we are the same day. This is our temporary crown going on that same exact implant. So your temporaries need to fit well. You need to be able, your temporary is going to control your soft tissue. So my biggest thing about doing an immediate implant in a case like this that has a crown on it is that it preserves your papilla. If you extract this tooth and you put some kind of a temporary in there, even if you do your best to get your ponic in there, you often lose most of the papilla. So I love it because here we've preserved our papilla and we have a very predictable result. This is our temporary crown process. I'm going to speed through these pretty quick. I used a lab analog. We go ahead and make this directly in the mouth over the implant. We have a mold of that tooth or a wax up on a model, and we're gonna have a negative. We're gonna go ahead and fill that with composite acrylic of some sort. We've already grafted the socket, and I blocked out whatever's not filled with graft with some collagen. We take this impression in the mouth with our acrylic material, and then we go ahead and trim it up on an analog and we polish it. So that's how we come up with these temporaries that fit pretty well to the tooth. Here we can see this is 3 months after we've done it. So we've got 3 months of healing time behind. You can see the composite temporary material is getting a little yellow because it's picking up some stain. And then here we go, here's our bone. 3 months after on the left, 5 months after on the right. So you can see that the bone has stayed stable. We don't see any sign of really significant bone change at all as it's healed. And here we are 6 months after we placed it. The tissue is now completely healed. We're going to go to our final crown. So here's an iTero scan. Digital scans. We use an iTero in our office. I love iTero. It's really high res and it gives us great pictures. But we're basically prepping this almost like we would do a natural tooth abutment. So on the right side of this screen, you can see that we have our final crown in place. We tried to match her adjacent teeth as close as we could. This is a zirconia fused to porcelain crown. So the facial is porcelain. The entire lingual is zirconia. And you know, the worst thing about it is now she notices a recession around her other crowns, which she doesn't notice around this one. But you can see the soft tissue is in the same position it was when we started. it never moved. So here we have a really good example of just being able to preserve the tissue. So these are just comparative views of a temporary versus our final crown from the palatal side. And this is just another picture of the day we put the crown on. So her facial smile shot shows that you really can't tell that we've done anything. So if I can leave the patient without anybody knowing I've done anything, I'm happy. This is a 1-year post-placement x-ray. Again, you can see the bone is now matured around the crest, and we've got all our micro threads covered. So I want to move on to another one. This is similar. So I'm going to do this one a little quicker because you guys have gone through it once, and I want to get to some other cases. So here we go with 2 lateral incisors. The guy had veneers, crowns that were replaced. He's 70 years old. He's in good health. This is very common. We see 70-year-olds, 80-year-olds, even some 90-year-olds come in here. My oldest implant patient was 98 years old. You know, this is very common. So he's a bit of a bruxer, so he beats the daylights out of these things, and he's busted up his crowns, and he's looking for something that's going to work that he doesn't have to re-cement every few months. So we're going to move through this one. Here's our planning screen. Here's our implant placement screen on the right. Same scenario. Here's our extractions. Again, atraumatic extractions, really important. And this one, we used a guide. We fabricated a 2-supported pilot guide. So I like guides, especially when they're 2-supported. I don't use them very often. Most of the time, I don't feel the need. This one was kind of small. We were trying to thread the needle on some bone here. So we did a 2-supported guide. Here we are drilling through our pilot guide. And here we are, implants in place the day of extractions. Here we are putting some silicone dam material on to make our temporaries. I don't have to block out all the way up to the margin on the abutment because all I need to do is capture the top part of the abutment, and then I slide the analog in there and I backfill all the acrylic to trim it on my holder. I don't know if that, I'm sorry I can't spend more time with this, but again, I get probably the coronal half of the implant is imprinted in here. Then I can slide my analog right in there and it'll fit. And then I backfill all this material and then I trim it back. So it's a pretty handy technique. It comes out with temporaries that look quite nice. And we cement them on with IRM, zinc oxide eugenol cement. Here we are the day of placement. There are both of our sides. And here we are with temporary crowns after it's healed for 5 months. And here we are with the way the soft tissue looks the day that we're doing our final crown prep. So we pull our temps off, we do some tissue retraction a lot of times. We're just going to place cord like we're doing regular crown and bridge. And here we are with mature tissues 8 months after implant placement. We got our final crowns in place on the right screen. And here we are again, just a couple more. Notice the papilla are there. We haven't lost our papilla. That's what makes me excited about doing these cases. That's where I'm saying I think we can get the same aesthetics you could get with a 2-stage implant or a 2-piece implant with these types of cases. So what do you know? The guy comes back a little while later and he's broken off into the crown. And now we're going to go into his front 2 teeth. Here's our planning screen. Here we got a couple more implants going in. And here we are, the implants are in place, day of extraction, and here's some temporary crowns in place. Now there's going to be something I want you to notice on this case. You can see that obviously my temporary crowns don't look as good as they did before on my previous one. And we've got an implant that's a little bit different position facially on one than the other. I planned it a little bit that way because that's the way the bone was. I was trying to avoid the nasopalatine canal. And we got one a little further forward. It's going to come back to bite me a little later, but it turns out okay in the end. So here we are in our crown prep day. Again, the same process we're going through here. So you can see cord packed around these things. We're trying to get the margins exposed for scanning. And here's iTero scan. Now you can see that we have an uneven gingival profile. One of them is set back further and the tissue has filled in more than the other. So this is what happens if they're not perfect identical twins. You can fix this on the prosthetic side. You can do a little bit of tissue manipulation and you can make your crown come out a little different, almost like a little bit of a ponic. I didn't do that on this case, and I'm going to show you what it looks like in the end. So here we go, is our final crowns in place, and we have one that looks a little longer than the other. I like the left one, which is the one I didn't place quite as well as I thought, more than the right one. So this could have been fixed prosthetically. We looked at it together, me and the patient, and we decided it was okay because this is his smile. He never shows the gingival margin of any of his crowns. So I got away with this one, but if I had a patient where they had a high smile line, I would have definitely sent this back to the lab. We would have done some tissue compression here. We would have done a little different design. So, but again, this is a great service for these people. They're super excited about it. They get their teeth right away. And here we see, again, total bone stability. We don't see hardly any changes in bone 13 months after we place the implants. And we're feeling pretty good about that. So I tell you what, we are how far on time? We got about 15 minutes. I'm going to show you this one even a little quicker. This is very similar, except we've got a bridge all the way across the front that's failing due to decay, some infection. He has a bridge in place, so we're going to replace this with some immediate implants. So I'll walk you through this one, and then we're going to move to some bigger cases. This guy wanted, so here we go. We've got our planning scan. We're going to put 4 implants in. We had a bridge that was abutted on the 2 cuspids. So we're going to put 6, 8, 9, and 11 is our plan for our implants, and here they are in place, day of placement. Here's our pre-op. Yeah, you can see some of there's some infection up in here. We can see there's decay around these. This whole bridge was broken loose, and there was decay on the other side. So that's the reasoning behind it. He didn't want to go through endos. He did not want to go through post and core and put another bridge in that he was afraid was going to break off. So here we are, day of surgery. Our implants are in place. We've grafted all the sockets. Basically, it was only 6 and 11 because 8 and 9, we didn't do any grafting because these were our original ponics for our bridge. So we did make a full incision on this case. This ridge was very narrow in the front, and we had to do some soft tissue management because his gingiva was about 4 to 5 millimeters thick where those old ponics were. So we had to do some tissue rearrangement here to reduce it down and get the tissue down, so we only had about a 2 millimeter thickness of tissue, which is what we wanted. So off we're going with our temporary in place, and this is 5 months post-op already. And here again, we see the bone is very stable at 5 months post-op. We see it right at the top of all the threads. We see all of our implants in place. Now, these aren't as evenly placed because we're following our prosthetic plan. He wanted to duplicate his bridge exactly the way his old bridge was. He did not want it to look perfect. He wanted it to look with variation. He did not want this to look like store-bought teeth. So here we go with our prosthetics, our arterial scan. We can see all the margins. We did use a reduction coping, I believe, on this case. I don't know if I have a picture of that here or not, but here we have our temporary bridge on the left and our final bridge on the right, which very closely duplicates his old bridge. It has some variation. We have some angulations. They're not perfect. We did build this bridge into occlusion, where his old bridge was not in occlusion because his dentist said, your teeth are too weak. I don't want you to have any stress on your old bridge, but it broke anyway. So anyway, he's got something now he can actually chew on in the front. So it's a great service to do. It's a fun thing to do. I really enjoy doing these types of cases. Here we are as our bridge has been submitted in place 7 months after the implants were placed. So I think I'm going to go ahead and skip forward here. Let's see here. Okay, nope, we just not go that one. Where's our first round? This one right here, okay. Excuse me for a second, I'm just moving around a little bit. I want to show you a roundhouse case that was done with one-piece dental implant. So this is a roundhouse case we did a few years ago, 33 years old. He was a smoker. didn't have good home care, didn't go to the dentist. We told them, hey, you're gonna have to change your ways. But we had a heart-to-heart conversation, and we told them, you know, you're gonna lose a bunch of teeth. So there was really nothing we could do. A lot of these teeth were infected. So we came up with a plan to completely replace all of his upper teeth with a fixed bridge and to rehabilitate his lower teeth. So, and he said, I'm going to quit smoking. I don't typically believe those folks. I'm sure you guys have run into this, but this guy actually did quit smoking for a whole year. And then he started again. So he did quit smoking for when we actually treated him, which was very helpful. So I was grateful for that. So here is our implant planning screen. Again, you're going to go through the same process that you probably would with any other type of implant, but you're going to know that you're going to be prepping some implants here because we can't get total parallelism on these bigger cases. There's no way it's going to happen. So, but this gives you an idea of what you're going to do as far as prepping goes before you even place your implants. I placed these without a guide. I've done several cases with a guide. I found out that when I do full arch rehabilitations, by the time I've extracted the teeth and placed my guide, it's very difficult to predict how the sockets are going to behave. And so oftentimes I make modifications that I don't have the flexibility with a guide. So I always encourage people, if you want to go to guided implant placement, be sure you know how to place your implants without a guide, because when you use your guide, you're going to be throwing away the guide. Sometimes you're going to get into a case where the guides are not going to be useful for you anymore because your extractions didn't turn out the way you planned them to turn out. I've had several full arch cases where I've done guides and I got halfway through the case and I placed half my implants with the guide and the rest of them I had to do freehand anyway. So I got to the point where I thought, you know what, I'm not sure that I'm enjoying this anymore. And I felt like I could get a better success rate doing it, planning the whole case myself and doing it without a guide. So the cases you're going to see are, none of these are done with guides on these full arch cases. Anyhow, having said all of that, we have a plan to do 8 implants on top, 1 on the bottom left. And here's our placement. You can see we're close to parallel, but we're not parallel. So we know that we're going to prep some of these implants. You can see the planning screen is very similar to the placement screen. And that's from both sides. This is the left side. And here we have our temporary bridge that we put in place the day we took out the teeth and placed the implants. So we extracted the teeth, we grafted the sockets, we placed the implants, and we have a temporary restoration all the way around in one visit. So obviously I'm not going to cover all of the prosthetics that go into that, but it's a fairly simplified technique. Once you, hopefully one day I can walk through and have a little more time to show some of you doctors how this actually happens. But you can see we're way down the road. We've cleaned the lower teeth. We've restored a whole bunch of decayed teeth down here. This guy's come a long ways and he's not smoking. So that's a good thing. Here we have him in his temporaries 5 months after we've placed him. And here we are the day we're doing final bridge prep. So you can see that we've got soft tissue management going on here. Some of these areas, the tissue has grown up over the margins. We've done some gingivoplasty, I call it. I do not use a laser. I have used a laser. I got tired of it because it was too slow for me. So basically I place cord. I use a diamond burr, a fine diamond, to do gingivoplasty where I need to expose margins. And we're back to crown and bridge. We're talking regular crown and bridge. We do scan these full arches, or you can take a polyvinyl impression, whichever you decide to do. Here's just a couple different views of that. Again, you can see how much he's healed up on the bottom. He's really cleaned up his act here. We've got teeth that look healthy now. These were all decayed, if you remember from the first pictures. He's made a huge turnaround. And here we see just PAs of temporaries. Our implant really isn't bent. We have a bent film here. But you can see that the bone levels look very nice. They're very stable. And we did a lower implant. This was kind of our bonus job here. Now this one, I did not get all the micro threads covered. You'll see though on his follow-ups that the bone stayed right there. The reason is that he had kind of a defect. We didn't want to trouble doing all the grafting to try to reconstruct that. So we were actually turned out okay. So here's an iTero scan of our full arch. And you can see that I can see almost every margin in one view. So my initial prepping the day of our placement and the day, sometimes I do some more prepping the day that we scan it, turned out pretty close. So here's just a quick example of using reduction copings. Labs, typically, my lab makes this for me. So they're going to do some reductions on the ones that they have a problem seeing all the margins. This is not the same case. I just took these pictures to show you how these work. So a lot of you guys hopefully are familiar with this. The reduction coping slides on to the implant. You're basically going to reduce back to the window that they've made in that acrylic coping. So you slide it on, it tells you where to cut, you cut back to the acrylic. Here you can see on your die, which the lab did for me on this case, and I've over-reduced the implant a little more than what they marked. So you're going to see this little white band when you put it back on the die. So I always do a little bit more than they show me to do, because then I know my restoration is going to fit. I'm not going to. So here we are pre-op. Here you can see the big change. You can see the tissues are all different on the bottom. He's healed up. We've done restorations. He's ready to go on the top. Pre-post treatment or post-implant placement pictures. Here we have our temporary bridge versus our final bridge. And this is a full contour zirconia. There's no porcelain on this at all. This is something that we are not going to have to worry about chipping or breakage down the road. And here's just some smile shots after we're all done placing his bridge. Here we go. We have some close-up shots. So the 3D zirconia is what we use. We really like that. It looks a lot better than the initial zirconias we first started using. But again, this is a full art zirconia. And here we are post placement with our final prosthesis in place. Again, I know you don't have a lot of time to look at this, but if you look closely, we really have stable bone. It just does not change. That's the benefit of these one-piece implants. This is 2 years and 8 months afterwards. Again, the same thing. We just don't see bone level changes very much at all. And unfortunately, he's back to smoking. So we've seen him since then. He's still staying stable. I think at this point, I'm going to stop, and we need to let people have a chance to ask some questions. So.
Perfect. So if anyone has any questions, they can just go ahead and raise their hand, and I'll go ahead and unmute your mic. Do you have any questions? Let's see. All right, I'm not seeing any questions right off the bat. Let me double check here.
If I don't see any questions, I can show another case if we have the time, or if you guys have something else you want to wrap up with here.
Oh, here's a question.
Okay.
Hold on. Dr. Delk has a question, so I'm going to go ahead and let her talk now. 1 second. All right,
Can
Dr.
you hear
Delk.
me? Hi,
Yep.
can you hear
Yep.
me? Okay. I have a question about the torque value. What torque value are you comfortable with when you place your implant?
Yeah.
Or passive loading?
For passive loading, I would want to see at least 40 for me. Some people go off 32, I hear, as a number thrown out there. I like to see them around 40. On a roundhouse case, though, where we're doing 8 implants, like you saw me just do, you can get away with things on a roundhouse you can't get away with on a single unit, because you've got cross-arch stabilization. So there's occasional times where there'll be 1 or 2 of those implants that may torque less than that. I'm fine with that. If a lot of these times these implants are torquing at 60, 70 even, especially with the OCO, because they have that auger tip on there. So that when that implant sees the torque values go extremely high in the last millimeter of placement. So, you know, it can be lower than that, and I'm fine because they're all stinted together.
Nice. Cool. Do we have any other questions here? Let's see.
I think it's Friday.
Yeah.
It's Friday.
Yeah. Cole, did you have one more case that maybe you could go over?
I do.
Sweet.
I've got several here.
Oh, here we go. Hold on one second. We got another question here. Dr. Kelly asked, when placing, are you submerging the prosthetic table? How far?
Yes, that's a great question, especially with immediate, and you saw this on some of those anterior cases. I am going to bury it a little further than you would probably think. So oftentimes when you're doing an anterior tooth, the palatal tissue is quite a bit higher than the facial tissue. So with a one-piece implant, like I showed you, that margin, so to speak, where the abutment stops is completely flat, okay? So you need to submerge it at least to bury those micro threads all the way on that palatal side by maybe even an extra 0.5 to 1 millimeter than you think. You're going to get a little bit, if that, oftentimes that socket bone is very thin, you're going to get just a little bit of breakdown just because you've extracted the tooth. If I have a difficult time getting it to seat any further, I'm not going to worry. Even if that tissue shrinks and that margin ends up being supragingival, I'm going to prep that margin. Okay, so I'm going to go back and drop that margin later. And we're going to make those margins, you know, when that tissue is healed. You saw me putting retraction cord in. So if my tissue, let's say it's a 3 millimeter tissue thickness, and all these one-piece implants have a 2 millimeter polished collar. So I'm going to bury that margin a little bit probably on those cases, and I'm going to retract that tissue, and I'm going to have a little bit of a subgingival margin. I don't have any problems cleaning cement on these because I can always explore that margin and I can feel it and I can clean it. I cement all these, of course, because you're not going to do screw-on. So I hope that answers your question. So it kind of depends. If you're doing an immediate case, I'm going to bury it a little further. If I'm doing a case where I have ideal tissue height and I'm not doing an immediate and it's got about a 2 millimeter tissue height, in other words, my tissue thickness is 2 millimeters, I'm going to put that margin right at the gingival margin. I'm going to place it right there or a teensy bit above and retract the tissue. If it's in the posterior, I'm going to place it right there. I'm going to put my margin right at the gum level. If it's an anterior, I might tend to bury it a little bit and retract the tissue.
Awesome. All right. Any other questions? Feel free to go ahead and raise your hand, and I'll turn on your mic. Here we go. He says, so bury all threads, adjust tissue as needed. That's what he's summarizing your answer as.
Yes, you're right. That's what you should do. So in some cases, you need to try to evaluate. I can see tissue thickness on my 3D scans pretty well. I use Anatomage. I love that software because I can adjust it. It's simple to work with. So I can usually get a pretty good idea on tissue thickness off of my 3D scan. Otherwise, when I'm in there placing my implant, before I even do my osteotomy, I'm going to take a perio probe. I'm going to poke it right through the tissue down to the bone. Okay, I'm going to measure that tissue thickness. If that thickness is 4 or 5 millimeters, I'm going to do some tissue reduction. I'm not going to do a closed technique anymore. I'm going to make an incision. I'm going to lift up that tissue and I'm going to do some thinning. I'm going to try to keep all the gingiva I can, but I'm going to thin it from the inside out, kind of like an inverted flap. And I'm going to drop that tissue down as close to 2 millimeters as I can get. So there are some cases where you're going to have to do some management like that. But I found out that even on my bone level implants, I'm going to end up doing the same thing. Because I don't like to have giant 5 millimeter collars on my bone level or my TSI implants either. It's just, they're a lot healthier if you keep that tissue not so thick.
Awesome. Dr. Kelly, does that suffice? I can turn on your mic if you'd like. Dr. Kelly, I've turned on your mic if you have any other questions for Dr. Loewen regarding the tissue. Perfect. He says all great. Cool. So any other questions? Let's see. We got a hand raised. All right, James Petroglia, I'm gonna go ahead and turn on your mic so you can ask Dr. Loewen the question. Cool. Dr. Petroglia, your mic is on now. Yep, we can hear you.
What do you cement the final restorations with? What do you cement the final restorations with?
Gotcha. I'm going to use glass ionomer resin modified cement. Same thing I use on my regular fixed crown and bridge. I use a GSIM product. If you're familiar with that, I believe that's a Fuji product, but I used to use a all resin cement. Infinity was one of the ones I used for a while. I didn't like it. It was too thick. But I like the GSIM simply because it's a strong cement. It's easier to clean, and it flows out. It doesn't tend to get embedded under tissue. So you need to have a cement that's not too. I would highly recommend a resin glass ionomer modified cement, and if your cement is really thick, I would think about finding something different. Just because you want to be able to get under there and clean it off. Hopefully you clean it off before it's totally set. It can be a real pain. But you want to make sure that your soft tissue is healthy. That's the biggest thing about doing cemented restorations, even at tissue level. You don't want to have tissue that's really boggy when you're cementing these crowns. The temporaries really need to fit nice, or in most cases where I put a one-piece implant in on a posterior, I don't put a temporary on it. I don't put anything on it. I just let them sit there. Most patients tolerate that really well. Now, the lower posterior, if it's lingually inclined a little bit, it's going to tend to tear up their tongue. So you got to be careful about those. But for the most part, the tissue health is so much nicer when they come back that I don't have a problem with cement getting under tissue at all. So just a couple of things to think about.
Awesome question, Dr. Petroglia. Does that answer your question? Sorry.
Yes, it was fine. Yeah.
Sweet. All right. Anything else? Anything else? That was a great presentation, Dr. Loewen. Let's see. Cool. So I guess at this point, I'll just hand it over to Tom. Let him do a little outro. Let me turn on his. Let me go ahead and.
I think I should be good now.
All right.
All right. Awesome. Thank you so much, Dr. Loewen, for doing this for us. It really means a lot, and it was really interesting. I definitely enjoyed it. Thank you, Dr. Delic, for joining us as well. As for all of you that have joined us tonight, I thank you. And do any of you have any questions for us as far as like OCO as a company? Anything that I can answer in regard to that?
Let's see. I'm not seeing anything here, Tom.
Okay. Well, hey, if you guys need my info, you'll be getting an email from myself or Taylor, and you can reach out to us anytime. We're here for you. And also, one thing to keep in mind is we are going to be sending a course survey and a quiz as well, and like Dr. Loewen touched on. So keep an eye out for that in your emails. You'll need to complete both of those in order to get your 1 CE. And the last thing as well, don't forget about the $100 that you can get off on your next order as long as you order within 30 days. So that's pretty much it for us. I appreciate all you guys coming. It was a good time. And hopefully we can do another one with Dr. Loewen sometime soon. This is really great.
Are you able to still hear me?
Yeah, yes, sir.
You might want to mention that Denver meeting you got coming up.
Thank you. Hey, you got my back. But anyway, yeah. So if you guys are interested, this let's see, October, I believe it's 8th and 9th.
7th and 8th.
7th and 8th. 7th and 8th. we have a Denver course. Dr. Duck will be there and Dr. Loewen will be there as well. So if any of you guys are interested in that, I have an email full of information I can send you, and you can just reach out to myself or Taylor or respond. Oh, it looks like we got a Q&A. Someone asked, a good course. I enjoyed the case study,
That's good. Thanks.
especially immediate full arches from Dr. Rowan. Thank you, Dr. Rowan. I appreciate that. This is definitely a great experience, and hopefully we can do another one with Dr. Loewen soon, and maybe one with a little bit more time as well, so you can dive into even more cases. So,
Yeah,
but
I tried to run through them.
yeah, no, this is perfect. But yeah, that's it for us. Thank you all for joining us, and I hope you all have a good weekend.
All right, thank you.
Yeah, thank you, Dr. Loewen. Thank you, Dr. Duck.
Okay,
Have a good weekend.
great weekend.
Have a
Thanks.
good weekend.
Bye.